Radiology as a specialty is very much intertwined with any hospital facility. We are almost 99% of the time having some image with almost every patient in the facility. We work from the sort of beginning to the end of when a patient gets seen in the ED to when they get discharged. We have some involvement with that patient more often than not. So all the services in hospital facilities we have some contact with. Where we do sort of our best is always reaching out and trying to provide assistance, answering questions, obviously making sure that how we can help improve the quality of that patient's experience and the timeliness of a diagnosis to the timeliness of getting the report to the clinician, and then length of stay in the hospital to keep it to a minimum. But let's talk about stroke care. It has gone through an evolution over the last few years, if not decade, from these sort of primary centers of excellence to a comprehensive center of excellence. You know, primary care center of excellence actually has a Joint Commission sort of criteria that you need to fulfill as a hospital facility, whereas comprehensive is still in the making. There are certain concepts, though, with both that clinicians in those facilities seem to understand, as well as, which is more important, to be honest with you, is EMS. You know, the providers who bring patients to facilities need to understand what facilities offer in order to make sure that those patients are treated appropriately in a timely manner. Sometimes they require transfer to a facility if that service, a comprehensive type stroke care, wasn't offered at the site that the EMS were to bring. And what happens for most time is these patients will come in with symptoms that a ED physician or EMS even might say is a early onset stroke. There is a timeline that needs to be in play when these patients come in so they know the proper management. You just don't give TPA to everybody with stroke. If they fall out of a window 6 to 8 hours, they would consider more of a systemic approach rather than more of a intra-arterial or thrombolytic approach. And they might even consider more of a non-TPA anticoagulation, antiplatelet therapy as opposed to the TPA regimen, because there are risks. And when you go and give thrombolytics to somebody who's outside the window, you may risk the fact that they could have a hemorrhage on top of a stroke that may not be hemorrhagic at the time. And you may do more damage. So it is important, timelines, history, timeliness the patients arrive in the facilities and that they go to the correct facilities for their care is important. So it is important the education goes beyond just the emergency department. And I think for most stroke centers, they have reached out to all of the extenders in the local environments and educated so that patients get directed properly.